Friends, I am extremely happy to introduce today's next speaker, Dr. Kaushik Rana. Dr. Kaushik Rana is associated with Jadis Hospitals, Vadodara, as consultant neurologist with a decade of extensive experience. He completed his graduation and post-graduation at Baroda Medical College. His career began as a senior resident in the Department of Baroda Medical College, followed by an assistant professorship at GMER Gotri Medical College, Vadodara. He pursued DM specialization in neurology and honed his expertise as a senior resident in the neurology department at SMS Medical College, Jaipur. Thank you very much. With this, I present you Dr. Kaushik Rana.
First of all, I am thankful to Federation of Family FFPI, Dr. Pragnesh sir, and organizing team for inviting me as a speaker. Regarding today's topic, management of acute CVA, my focus will be mainly clinical, where we identification of acute stroke. Then what are the recent practices going on, then secondary prevention and primary prevention, what we can do at our level. Why it is important to know about stroke? Because stroke is the second most leading cause of death in India. So, and 60% of the people of stroke, they end up with disability. As we know, theoretically, I am not going to discuss many things. There are two types of stroke, is hemorrhagic stroke and ischemic stroke. My one question, whenever any patients present to you with hemiparesis or in whom you are suspecting stroke, so aspirin empirically can be given or not? Yes, that's my point. Because until unless we know what type of stroke, we should not give empirical treatment. Regarding risk factor, we all know cardiac and stroke, both the pathology is same, vascular etiology. So the risk factor, there are certain uncontrollable risk factor like as the age progress, the incidence of stroke, family history. Then some are controllable risk factor like blood pressure, hypertension, atrial fibrillation, hypercholesterolemia, smoking, diabetes, poor circulation, lack of physical activity. So the importance of risk factor is also there, so we can modify them to prevent the stroke. So the most important thing, how do I know if someone is having stroke? Because some patient, they come to you clinically, कैसे पता लगेगा कि पेशेंट में स्ट्रोक कब सस्पेक्ट करना है? So whenever there is severe sudden onset of headache, patient comes with sudden onset of headache, then dizziness, some imbalance in walking, then sudden onset of unconsciousness, अचानक patient unconscious लेके आए, then visual disturbance, some patient they started developing sudden onset of loss of vision or some blurring of vision, then difficulty in talking, then sudden onset of confusion or problem understanding what is being said, that is aphasia. Sometimes patient develops Wernicke's aphasia, they talk irrelevantly and we may think of some psychiatric problem may occur. Then there is drooling of mouth, sudden deviation of face and weakness, as we know, paralysis. The importance of this slide is any sudden event, neurological symptoms which occur suddenly, then the first possible things or possible diagnosis is something happen in the brain. Most common reason is stroke. Then there are certain atypical stroke presentations like movement disorders. Stroke can present with movement disorders like acute hemiballismus, movement disorders, then sudden confusion, then hemi-neglect syndrome. If patient is having right parietal lobe stroke, then they may ignore their left side of the paralytic side. They just walk, see on the right side of. So this kind of presentation can occur. Then loss of sensation, cortical blindness, as I told, sudden onset of vision loss. These all the common presentation of stroke. Then there is a mnemonic, be fast. I request all of you to to keep this slide in your waiting area, so that all the patients and the relatives, they can come to know, okay, what are the signs of stroke when they come to you and refer to some hospitals. Like B for balance, loss of balance, sudden onset of loss of balance. Then eyes, E for eyes, sudden onset of loss of vision. Then face, sudden onset of face drop. Then arm, sudden onset of weakness in the arm. Then speech difficulty. If anything occurs suddenly, if any of the symptoms, they are the signs, they are the symptoms of stroke. So, and it is a time to call ambulance and refer patients to higher center is needed. Then there are certain stroke mimickers. Stroke mimickers, matlab, there are so many conditions in which stroke-like presentations can occur. Most important is hypoglycemia, then seizure, migraine. Some hemiplegic migraine patients may develop recurrent hemiparesis associated with headache. Then toxic, metabolic, then brain tumors, conversion reaction, demyelination, syncope. So all these, there are so many, there are list of non-stroke conditions. I told my students to check one investigation. What is the most important investigation if any patient presents to you in your clinic? Which investigation you do at your clinic level? Blood sugar, yes. Or if any neurological patient comes, whether it is a headache, seizure, weakness, just check blood sugar, because sometimes hypoglycemia can mimic, can present as various symptoms. So it is a very treatable condition. Just hypoglycemia can detect with just blood sugar testing. You can give glucose solution and patients may become all right. So now you make a suspect a diagnosis of stroke. Now when to refer? Where to refer? There is concept of stroke-ready hospital. Why it is required to refer patients to a stroke-ready hospital, that I will discuss later. The hospital which has all the facilities, CT scan, MRI, at least CT scan should be there, then cath lab and proper ICU facility to manage stroke. Regarding imaging, which is the best imaging modality for acute stroke? Okay, yes. CT scan is enough. There is no need to do MRI for diagnosis of stroke. So this is a guideline given by American Heart Association. So non-contrast CT scan is equally efficient to diagnose stroke, to exclude intracerebral hemorrhage. Our main purpose is to exclude, to decide the type of stroke, whether it is hemorrhagic stroke or ischemic stroke. If it is diagnosed, then there are treatment guideline is there. The MRI, the role of MRI is in certain condition to rule out certain stroke mimickers. But for initiating treatment, CT scan is enough. So the other diagnostic tests, see, only assessment of blood glucose is required. No other test is required for management of stroke. So after referring patient, after doing CT scan, we can come to know various type of stroke. This is ischemic stroke, hemorrhagic stroke, there is hyperdensity in the CT scan, and this is subarachnoid hemorrhage. So by doing as in cardiac patient, by doing ECG, by doing in neurology, by doing CT scan, we can come to know what types of stroke is this. Right? Then in MRI, there are various type of stroke. Depending upon the vessels involved, we can see various kind of presentation. Patient may have middle cerebral artery stroke, that the branch of middle cerebral artery, anterior middle cerebral artery and posterior, and depending upon that, patient can present with various clinical syndrome. Like if patient is having main MCA block, then patient may have global aphasia or complete hemiplegia. If patient is having anterior MCA, then patient, if it is in a language dominant hemisphere, then patient may present with just Broca's aphasia. In posterior MCA territory stroke, patient may present with Wernicke's aphasia alone. Then cortical, sometimes some embolic stroke can occur, some cardioembolic stroke or atheroembolic stroke, then they can present with cortical MCA territory. Then small vessel disease, perforators, then PCA territory, posterior cerebral artery stroke. These kind of patients, they present with just isolated vision loss, no neurological, no other motor deficit, just isolated vision loss. Then sometimes ACA territory, anterior cerebral artery stroke, this kind of patient, they present with isolated leg weakness. Sometimes patient presents with just foot drop and they have a stroke. So depending upon the area involved, patient presentation is varied, and so it is very much important to think stroke in any neurological patient who present with sudden onset of the symptoms. Now, why it is important to refer the patient? Suppose this is a slide, this is middle cerebral artery which supplies this much area of the brain, and there is occlusion here. And in this slide, this is a time and volume of the infarct, and the black portion is the dead tissue. In the brain, it 4 seconds is required for oxygen, and a 6 to 10 second is required for glucose. So if oxygen is delayed after 4 seconds, then the neuronal injury can started. So it is important to open these vessels. See, after 2 hours, as the time progresses, the dead tissue is increased. This is after 24 hours. If we are not able to open the vessels, then this much tissue we are going to lose. And if this patient, they cannot walk or they develop permanent disability, lifelong disability, if we cannot open the middle cerebral artery timely. So regarding treatment, there are reperfusion therapy to open the vessels, IV thrombolysis, and second is mechanical thrombectomy. IV thrombolysis, the 2 agents are currently recommended, tissue plasminogen activator and tinectaplase. Both has equal efficacy. The advantage of tinectaplase is we can give it is in a bolus form, whereas this tissue plasminogen activator we have to give on infusion therapy. So it over a period of 1 hour, and this tinectaplase we can give just a bolus therapy. Both have equal efficacy in managing stroke. Then if patient is having large artery stroke, then we can offer mechanical thrombectomy. Means we can remove the clot by retrievable stent, or we can aspirate the clot. I will like to discuss one case. 69-year female, hypertension, diabetes. Just 10 days back she underwent a left hip replacement. Now she presented with acute onset of right-sided hemiplegia and aphasia of 2 hours duration. NIHS score 18. The score can be decided by clinical presentation only. And this is her MRI. Can you see hyperintensity? This is diffusion weighted image. This is flare image. These all are old changes, but we are more interested in this diffusion weighted image. In MRI, there is no hyperintense signal in this area. So it is a diffusion flare mismatch. And this is an ideal candidate for reperfusion therapy. If this patient is showing hyperintense signal in this area, so it is already infarct tissue, and patient may not benefit with reperfusion therapy. And this is MR angiogram. You see, this is right side this is middle cerebral artery and branch, and beyond this there is no flow. So it is a left MCA territory stroke. So now what thing to be done? दोनों में से क्या मतलब ट्रीटमेंट ऑप्शन, वेदर टू गिव आईवी थ्रोम्बोलिसिस और नॉट, और डायरेक्टली पेशेंट शुड गो फॉर मैकेनिकल थ्रोम्बेक्टोमी? Pardon? See, patient underwent hip replacement just 10 days back. So it is a contraindication for IV thrombolysis. Any surgery in previous 3 months, head injury, bleeding tendency, these all are contraindication for giving IV thrombolysis. So for ideal treatment for her will be mechanical thrombectomy. So in this patient we did mechanical thrombectomy. See this, can you appreciate the arrow? Beyond this there is no flow, and after removing the clot, the flow is established. And this is on day 3. Just 1 minute. See, patient is having complete hemiplegia at the time of admission 0/5, or on the day 3 we can achieve her to mobilize. So if the vessels can, if we are not able to open the vessels, then patient may remain bed bound for the lifelong time. So these are the current guideline, practical guideline. If patient symptom onset, patient presence within 4.5 hours, then if patient is eligible, there is no contraindication for IV thrombolysis, then we can give IV thrombolysis. Beyond 4.5 to 24 hours, it should not be given as per the guideline, but we can decide on case-to-case basis. If there is diffusion flare mismatch is there and patient is eligible, then we can also give. But it is in a rare case-to-case scenario. But if patient presents within 4.5 hours, then IV thrombolysis is the ideal treatment of choice. Beyond 24 hours, standard evaluation and care, matlab antiplatelet therapy, general nursing care, and other supportive treatment. After
Sir,
that,
Sir, 2 minutes are there. Sir, Rana sir, 2 minutes.
okay, sir, just one. If large vessel occlusion is there, then we can go for mechanical thrombectomy. Regarding antiplatelet therapy, administration of aspirin, if patient underwent IV thrombolysis, then it should be started after 24 hours. If patient did not receive IV thrombolysis, then dual antiplatelet should be started as early as possible. Other therapeutic agents, they are not recommended to give. Only aspirin and clopidogrel is recommended to give. Regarding blood pressure management, if patient is entitled to less than 185/110 millimeter is the ideal treatment goal for the blood pressure if patient is planned for IV thrombolysis. When to reduce blood pressure acutely? In presence of heart failure, aortic dissection, preeclampsia, or any coronary event, then we need to reduce blood pressure also. Now, after the stroke, secondary prevention is more important. Antithrombotic therapy, dual antiplatelet therapy, management of risk factor like hyperlipidemia. Then if patient is having large vessel occlusion like carotid stenosis, then we can offer patient to carotid endarterectomy, stenting. Then other risk factor management. Then educations, continuation of treatment, and what to do in emergency. Education of the family and family members should be there. Then this is for primary prevention. Before, how to prevent stroke. This guideline is given by American Heart Association for optimal brain health. Hypertension, blood pressure should be less than 120/80, fasting blood glucose less than 110, then cholesterol should be less than 200 milligram, non-smoking status, then moderate physical activity for more than 150 minutes and vigorous activity more than 75, body mass index less than 25, and healthy diet like fruits, vegetables, fish oil, then fiber rich diet, low sodium diet, and avoid sugar sweetener, right? So for concluding, in the stroke, prevention is better than the cure. So at family physicians level, we need to modify the modifiable risk factor for management of the stroke. Then whenever stroke strike, act fast. We need only non-contrast CT scan to treat. And acute therapy is available and it is effective. And other supportive care should be there, like blood pressure management, sugar management, and general nursing care. And awareness about the complications and education about the secondary stroke prevention. So stroke is not just treated by just only neurologist or some neurointerventionist. It is a stroke team, and it started with you, patient, neurologist, intensivist, neurointerventionist, and emergency specialist. Thank you.